Many of you might recall the early days back when I first described this syndrome when it was called yuppie flu. Time magazine showed a picture of a middle-aged woman with a dreary look on her face, and it was dubbed yuppie flu. And the real reason probably was because people in that socioeconomic category were able to seek medical care. And what happened to me individually was I had this practice at Lake Tahoe, as you saw, that was laid back, quiet, healthy people, skiing, jogging, doing everything else. And suddenly in the fall of 1984, 189 of them became severely ill with a flu-like illness, from which most of them have still not recovered. We then went on to learn a little bit more about it, and you probably are aware of the early to late 80s when the syndrome became known as chronic fatigue immune dysfunction syndrome. That was largely driven by the patient support groups that wanted recognition for the fact that one of the characteristic hallmarks of the disorder was immune deficiency. Then in 1988, the CDC established their definition for chronic fatigue syndrome, which were called the Holmes criteria. And for any of you who have ever worked with the Holmes criteria, they're research criteria that are used to study very specific groups of patients presenting with certain illness patterns, and it's what the CDC is famous for doing. They found it quite restrictive because it basically has a predisposition to select for patients who have a post-infectious onset. And the reason for that is all of the patients at Tahoe, at Lyndonville, and other places where there are outbreaks in the United States presented after acute flu-like illness. And today, at least 60 or 70% of the patients who present with chronic fatigue syndrome present after an acute viral or flu-like illness, although there are other onsets. So that particular definition was subsequently revised, and I will be going over the Fukuda criteria just as a review for many of you. And then the syndrome became named chronic fatigue syndrome in the United States. Now, there's been this historical debate as to whether or not it's the same thing as what's called in the UK myalgic encephalomyelitis. And the history of encephalomyelitis goes back much, much further to outbreaks that were described in the Royal Free Hospital in London, and maybe longer than that, epidemic neuromyasthenia, etc. So the literature actually has a number of similar epidemic that sound very, very similar to the Lake Tahoe yuppie flu, actually. Interestingly, in Japan, the syndrome is called low natural killer cell function syndrome, after the most predominant immune symptom, which is low natural killer cell function. I'll go into that in some detail, and you'll see why that is. So I want to dispel some myths here. And the first one is that ME or CFS is a relatively rare disorder. And for the purposes of this discussion today, I'll consider ME and CFS to be the same thing, although there may be some technological differences. And the fact is the prevalence in the United States is 200 to 400 per 100,000, meaning at least 500,000 people in the United States have chronic fatigue syndrome, although the CDC now estimates that 85% of the people are undiagnosed. So maybe that number is closer to 2 to 3 million. If you use a similar statistic in Ireland, that means you have at least 20,000 people in this country that should be diagnosed, and perhaps only 15% of them are being diagnosed. So you could have closer to 100,000. And those statistics have held up pretty much worldwide, regardless of what country you've looked at, even in the undeveloped countries. The economic loss is actually staggering, and this is why I think every country, every support group, every physician, every medical society needs to pay attention to this. Because of the severe disabling nature of the disease and the fact that most of the patients who suffer from CFS or ME are disabled, the cost is estimated in the U.S. to be $9 billion per year in loss. And that's not including the loss to the medical system of the care that's consumed by these patients. This is just the economic loss of not working and collecting Social Security, etc. It's a staggering amount of money. It's equal to about a day in Iraq. Prevalence of CFS in the U.S., the CDC again now estimates that there's over 1 million patients. The market potential was another angle to look at this. If you had a diagnostic marker, so we could do one test on everybody who presented with fatigue to see if they had CFS or ME, it'd be a $120 million market per year in the US alone. That's a humongous market potential for a diagnostic marker. And if you had an effective therapy that was licensed and recognized, it's estimated that it would be at least $250 million a year market in the US, which should make it a large enough market that the drug industry should be interested in developing a drug. Myth number 2, my favorite, is that the disease is just amongst the young, affluent, white professional women. And in fact, women, men, and children from all socioeconomic backgrounds are affected by CFS and ME. Women do have a higher gender ratio. In my particular practice, it's about 70% women, 30% men, and there are a number of reasons why that may be the case. I think men underreport their illness as part of it. There may also be a bias for genetic reasons. This was a study that was done in Chicago that totally dispelled the white female myth. And in fact, chronic fatigue syndrome is more prevalent amongst Latinos and Africans than Caucasians in the city of Chicago. I think the underreporting has been we simply didn't look. These are patient groups that are hard to access, they're hard to survey, they don't have as much access to medical care, but they clearly have the disease. I think the most overlooked population is probably the kids. Until just last year, there was not a pediatric definition for chronic fatigue syndrome. In fact, kids were excluded. Children are under-recognized, understudied, and miscategorized. Many of them are accused of having school phobia. They may even be taken from their parents. They may be placed in psychiatric hospitals, etc. My concern about pediatric chronic fatigue syndrome, here's a young man of mine who was bedridden, had missed 3 years of school prior to his being treated. It has a great impact on social and economic achievement and sometimes results in a lifetime disability at a very susceptible young age. So I take children with CFS very seriously. The third myth is that chronic fatigue syndrome is just a form of depression. And I understand that's a particular problem in Europe and other societies, perhaps more so of a problem than we have in the United States. And the fact of the matter is that chronic fatigue differs from depression in many ways, almost differs more than it's similar. So I'll spend a little bit of time on this going over my thoughts. First of all, the onset is different. The incidence is different. The major symptoms are different. The attributions are different. The lab tests are different, response to treatment is different, rehabilitation is different, and even gene expression in chronic fatigue and depression are different. Here's a study we did looking at immune parameters in 3 groups of patients, in depressed patients, in normal controls, and in chronic fatigue patients. And you'll find that in looking at the immune systems of these groups of patients, the controls and the depressed looked about the same. The chronic fatigue patients were the blue figures, totally different. It was very easy to discriminate them. In fact, I could make the diagnosis simply based on 5 immune tests. So in summary, chronic fatigue syndrome can be distinguished from major depression based on the tests like the RNA cell ratio, increased interferon, decreased natural killer cell function, and greater self-impairment. In fact, on standardized scales such as the FF36, KPS, MSQ, any of these quality of life scores, chronic fatigue ME patients score much lower than depressed patients. That's because depressed patients have lots of symptoms, but they actually remain very functional. Now, if you look at the common symptoms, of course, you can see where the confusion comes about, particularly for GPs and other people out there that are very busy. It's not uncommon for a patient to present to the office and say, well, I've got fatigue, fibromyalgia, sleep disorder, depression, headache, sore throat, anxiety, muscle weakness, blurred vision, nausea, post-exertional malaise, tachycardia, blah, 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 blah. And pretty soon your 3 minutes with your GP is over, and your GP says, well, you sound depressed. Okay. Or maybe if they're slightly more enlightened, well, you might have that fatigue thing. but the array of symptoms and the multi-systems that are involved certainly contribute to some of this confusion, particularly to the ill-informed. Precipitating factors may be helpful. Up to 85% of the patients can report to you exactly when they became ill. Exactly. To the day, sometimes to the hour. That implies that the onset or the precipitating event was some type of infection, either bacterial or viral infection. We also see it post-trauma, after an auto accident, or after childbirth, sometimes after an allergic reaction, or sometimes a major stress such as a divorce or large court settlement or something like that. Those are all factors that can impair your immune system, of course. So in 1994, the CDC was going to solve this, like I said, and they were going to make criteria for the diagnosis that was to be used by everything for determining the presence of chronic fatigue syndrome. And they established the criteria that you all know, and I'll just go over them very briefly for sake of understanding parts of them. You must have persistent or relapsing fatigue of 6 months or longer of duration. Everything else known to man that can cause fatigue must be ruled out. The United States now, in order to do that, that costs about $15,000 to rule out everything else that you don't have. You must have concurrent symptoms either impaired for the following: impaired memory, sore throat, tender lymph nodes, muscle pain, joint pains, new headaches, unrefreshing sleep, or post-exertional malaise. And I find actually the most helpful symptom is the post-exertional malaise. There's very, very few diseases where you feel worse after exercise, or in fact where you may be bedridden after exercise, or where you can do nothing after exercise. Certainly patients with depression, for example, feel better after exercise. So to look at this, the fatigue is not the result of exertion, it's not alleviated by rest, and it must substantially reduce your occupational, educational, social, or personal activities by at least 50%. Now, this part of the criteria has caused us all kinds of problems, because if you're looking at a disability judge, how do you document that your personal activity has been diminished by 50%? Or how do you document that you've had a substantial occupational reduction? It's a big sticky point in the U.S. in terms of our legal definitions and when patients are applying for disability, etc. Then you must have 4 of the 8 symptoms, and I've reviewed those. The short-term memory or concentration is important. Patients describe this as brain fog. Their brains just don't work right. There's been a lot of neurocognitive studies that show what that is. The processor is just slow. It's not a dementia. The information's there. You just can't get to it. So given time, you find the name of the object you were trying to name. But at the time, it was very slow getting there. And I'm sure any of the patients here can empathize with that. Sore throat is still very common, although it's more common in the patients with the post-viral fatigue states. Tender lymph nodes are part of this 94 definition. And that was because it was one of the few physical signs that was persistent. Joint aches and pains, new onset headaches, non-refreshing sleep. Non-refreshing sleep is seen almost in 100% of patients. Whether or not it's an absolute critical feature or not remains to be determined, but I can tell you that even if you restore sleep, you continue with your other symptoms, in my experience. And again, the post-exertional malaise lasting more than 24 hours is very characteristic. So in 2003, the Canadian government set out to make a clinical definition that was more useful for clinicians and perhaps included fewer people that had other diagnoses, such as comorbid diagnoses. And they wanted to look at this from the standpoint of a universal definition that could be utilized by all primary care doctors around the world. So they established what was been called the Canadian Consensus Document, and it's the definition that I, in fact, use in my practice. And I would advocate all physicians around the world to adopt this definition so that we're finally utilizing the same definition. So if I'm talking to your doctor in Ireland, we're talking about the same disease process. There's some debate about that. In my opinion, it should have been called the International consensus document, since a number of people from around the world were on this particular working committee. And the Canadian Clinical Working Definition is similar, but it differs in some important ways. So I'm going to spend a few moments outlining that with you. First of all, you must have fatigue, post-exertional malaise, sleep dysfunction, and pain. So that way it's very similar to previous definitions. But it adds 2 or more neurological, cognitive, or symptoms from the autonomic, neuroendocrine, and immune manifestations. And that you'll recognize yourself, any patients. You'll see what it now addresses in the Canadian definition that was missing in previous definitions. So fatigue, we've talked about the fatigue. The post-exertional malaise, I'll come back to that in a minute. The sleep dysfunction, it now includes pain. There's always been a debate about whether CFS really is associated with pain or if that crosses over into that big category of disease called fibromyalgia. Neurological and cognitive manifestations, 2 or more of those, and we'll look a bit at those. I've yet to see a single patient that does not complain of some neurocognitive dysfunction. And in fact, if one would come to me and say, no, I'm perfectly clear, I don't have any problems with memory, I don't have any problems with it, I would say they don't have chronic fatigue. And then at least one symptom from autonomic manifestation, neuroendocrine, or immune. And then again, it must be at least 6 months duration with a distinct onset. The Canadian consensus document is a little softer on people who had a gradual onset. And of these neurological cognitive manifestations, most of you will probably recognize yourselves here. Confusion, impairment of concentration, difficulty with information processing, particularly word retrieval, disorientation, perceptual and sensory disturbances, ataxia, which is a balance problem, muscle weakness, muscle twitches, overload phenomena. In other words, if something gets complicated, I can't do it. If it's simple enough, I can do it. The fatigue, again, in detail, new onset, it can't be fatigued your whole life. Unexplained, it can't be because you have some muscle disease. Persistent and recurrent, and substantially reduce your activity level. The post-exertional aspect has been, again, emphasized. It's inappropriate disability relative to the exercise. This could be very simple. This can be, I went shopping on Saturday and spent a week in bed. It's a very, very important part of this diagnosis. It's also, people say their cognitive dysfunction worsens with exercise as well. So it's not, or that mental exercise, such as preparing your tax return, can cause a physical relapse of symptoms. And a pathologically slow recovery of 24 hours or longer, that rest doesn't make it better. There's huge parts of the U.S. research dollar is now going to post-exertional malaise because we should be able to define what that is on a molecular basis that's causing that. The sleep dysfunction, as you all probably experience, unrefreshed sleep. You spend a lot of time in bed and don't feel any better. The sleep quantity may be impaired. It might actually be increased. There are rhythm disturbances. Most often when you do formal sleep studies, which you've all probably had, you'll find that you've had alpha intrusion into delta sleep. So you don't get restorative sleep, and that's documented on a sleep study. I do sleep studies on each and every patient because sometimes patients have sleep apnea on top of it, and sleep apnea is treatable. Pain. Pain was not emphasized in any of the other definitions. It's significant myalgia. It's deep kind of muscle pain. It's different than arthritis pain. It's often widespread or migratory. It can be one place hurt one day, one place hurt the next day, rather than persistent, oh, my knee hurts all the time. Headaches of a new type that are refractory to treatment are very, very common. Oftentimes the patients end up at a migraine clinic or something, and none of the migraine drugs work. Other symptoms, and here's where the Canadian consensus definition really differs from other definitions. It now acknowledges orthostatic intolerance or neurally mediated hypotension. You get dizzy when you stand up, or you get a fast heart rate when you stand up, or you have a fast heart rate at rest for no reason. My heart's just pounding, people say. Lightheadedness, paleness, nausea, irritable bowel symptoms, urinary symptoms, exertional dyspnea, Those are all related to autonomic dysfunction, which we know is part and parcel of the disease. Neuroendocrine has been well documented. It's been studied. The statistics are clear on it. People have loss of regulatory function. They always, oftentimes my nurse will say, well, their temperature is only 96. And I'll say if it was 96, they'd be dead. But in fact, their temperature is 96. They have lost the ability to regulate their temperature in a normal way. Marked weight change, either up or down, usually up. And loss of adaptability to situations around. The immune manifestations have not changed from the original definition. Tender lymph nodes, these sometimes come and go. These may be very, very important. And I caution any of the patients in the room who have tender lymph nodes to be very, very careful and bring those to the attention of your treating physician, because a subset of patients has gone on to develop lymphoma. Recurrent flu-like symptoms are very common. People say, I feel like I have the flu all the time. Generalized malaise. And one thing that patients always tell us, and we rarely listen to, is new sensitivity to food, medications, or chemicals. And woe unto you if you get a doctor who doesn't believe you about that, because they'll give you a regular dose of something and you're certain to have a reaction, a skin rash, intolerance, nausea, headache, or something from a dose that would have been tolerated very well by a non-chronic fatigue patient. And that's due to immune upregulation. Illness duration, again, persistent of at least 6 months, distinct onset. Diagnosis can be made earlier if you meet all the criteria. That's a change in the Canadian consensus. And children can be diagnosed even earlier. Immune function, there are hallmarks that have been seen around the world, and I just want to inform you about all that because it's often said there's no markers, there's no way to really diagnose this properly, and I don't really think that that is true. Chronic fatigue patients, the hallmark is low NK cell function. Natural killer cells are part of your primary innate immune system. They're one of the first things that recognizes an infection. Their sharks only have natural killer cells. They're first responders. Chronic fatigue patients have very low natural killer numbers and function, sometimes in the 2 to 3% range, 2 to 3% of normal in your first response in your innate immune system. This is true around the world. That's why the Japanese called it low natural killer cell function. If I only had $221 to spare, I would spend it having my natural killer cell function measured. So you know that. It's one of the cheapest immune tests out there. We have elevated cytokines, and that's what probably makes you feel so badly. I could give a whole talk just on the cytokine arrays and what we've learned about the different cytokines and how there are patterns of recognition and how various patients fall into different patterns, Th1, Th2, etc. So it'll be beyond the scope of this particular talk. But we know there's cytokine panels, messengers that probably are responsible for making you feel so badly. If I infuse you with interferon, you will feel like you have the flu. Some of the patients have interferon levels of 5,000, 10,000, with normal being less than 10. If you look at one of the markers like IL-8, interleukin-8, normally not detectable in the serum. Some of my patients have levels of 70 or 80,000, indicating that your immune system is super revved up. The RNA cell, the antiviral pathway is increased. There's an abnormal fraction that we've heard a lot of results from, and currently it's being sequenced, and there's rapid tests so that we can give you these diagnostic markers in a faster, more reliable way. And then there's evidence of viral reactivation. A subset of patients, about 55 or 65%, have evidence of viral reactivation. Some may be the original virus that they had that was the onset of their illness. It may be another virus. The herpes viruses, we're never rid of them. We have them for life, and they reactivate during periods of stress. So, again, to summarize the immune abnormalities we've seen in chronic fatigue syndrome, there's evidence of immune activation. Every laboratory that has looked at this, there's a Th2 cytokine shift. There's pro-inflammatory cytokines, TNF-alpha, IL-1, IL-6, now I'll add IL-8, 10, and 12 to that as they've looked at. There are panels now that will give you all 25 cytokines in one panel. It's very efficient. It tells you where you are with respect to those particular markers. With respect to the functional defects, we know natural killer cell function is low, macrophages malfunction, the CD8 abnormalities, a regulatory cell in the immune system is not functioning properly. And this is universally. This is based on studies we've done in Australia, New Zealand, Belgium, the UK, United States, and I believe many are based in Ireland. The 2,5-A pathway is particularly interesting because it's involved in killing viruses. It's a natural pathway that we use to kill viruses. And there's characteristic abnormalities reported, again, worldwide. The French did a lot of work in this field. Noted that the system is turned on, and it's turned on in response to something. The antigen, you're fighting something. Dysregulation is seen even in the absence of virus with a high 2,5-A, high bioactive 2,5-A, and this abnormal form of RNA cell that, again, that doesn't bind regulatory inhibitor very well. It's abnormally active. It results probably in a number of the symptoms that you all are suffering from. Interestingly, when you correlate the immune abnormalities with your functional score, you get a direct correlation. So the patients with the most impaired immune system have the lowest functional status. And that's very important when you talk about things like drug development, because when we don't have a marker for the disease, we have to use endpoints like the MSQ, which is a quality of life score. So if a drug improved your MSQ or your quality of life, we would also expect it to improve these immune parameters. That's why this is so important to research. Negative correlations are similar with KPS, quality of life, and immune parameters. And what that means is the people with the more functional status, the people who are 80 or 95% functional, have fewer immune abnormalities, as you would predict perhaps. Here's a slide that just demonstrates when we put these particular markers, and I just took 6 of them for the purposes of this talk, and I put 6 of these immune markers together on a group of patients, and you can clearly see that the depressed and the controls look about the same, and the chronic fatigue patients look totally different, just on 6 immune markers. So I could take these 6 tests on you, and I could tell you whether you were controlled, depressed, or a patient. And the control groups we use, by the way, are both healthy controls, but also other disease controls: rheumatoid arthritis, osteoarthritis, HIV disease, etc. So the statement that there's really no diagnostic tests for chronic fatigue syndrome is really not quite accurate. You can look at a panel and put yourself very accurately in a diagnostic category. And again, I go back to this canonical distribution that is a different way of looking at the same data, and you see there's no crossover. There's no depressed people that look like chronic fatigue patients, and there's no chronic fatigue patients that look like depressed people when we look at their immune parameters. Well, let's look at the aerobic energy system, because if you really think about it, if we're talking about fatigue, it's failure to produce energy in a proper way, and it should be solvable, right? And it should be pretty easy to research and to understand. The problem is all the standard things we've done to look at it have not been helpful. We have done muscle biopsies, we've done EM on muscle tissues, we've looked at the muscle enzyme. It's not a muscle disease. It's a disease of failure to produce energy. So it's going to be on a molecular base. It's going to be an ATP problem. And that's where the new research is going, is to see what is wrong in the mitochondria. Is it being poisoned? Is it genetically defective to begin with? Is there some agent that's causing it to be impaired? Well, you all know what aerobic impairment is. You can't do what you're supposed to do, which translates to a functional incapacity. There are people who could run 10 miles and now they couldn't walk 10 feet. So functional impairment is very real. And the link to immune dysfunction has been looked at a great deal and will continue to be looked at, both as a linked phenomenon and also as perhaps a cause and effect. And we look at oxidative impairment in chronic fatigue syndrome from a variety of different ways. And gene expression studies, interestingly, have shown that your messenger RNA is impaired in the energy pathways almost universally. So it means that on a day-to-day functional basis, the genes that control your mitochondrial function are impaired. So we've made that progress, but we don't know why they're impaired. We know that you have a low VO2 max during stress testing, oftentimes half of a normal person, which means you have no reserve even if you wanted to. So you're not lazy slob, you can't do it. Oxidative damage to DNA is another hypothesis. Poor recovery ATP is another hypothesis. These are all being tested to see why you have impairment of energy production. Now, if we look at standard US guidelines, in the United States, if you have a peak VO2 max of under 20, you have presumptive disability. So it doesn't matter what caused it, doesn't matter. Back injury, whatever, if your VO2 max is under 20. So that's why you see down there the moderate to severe peak VO2 max of 20 and below. And you'll see that over half the patients fell under that criteria. And that's interestingly how I qualify people for disability in the United States, based on a low VO2 max, based on your measurable fatigue, not based on all the other symptoms that you have. And you'll also note that the VO2 max of under 20 is far worse than people with heart disease. They're generally in the 20 to 25 range. Dr. Stevens has done an interesting study to document the post-exertional malaise that you all complain about, and she did it very cleverly. She did 2 treadmills sequential days, day 1 and day 2, just to see what the difference was. And normals in the blue perform exactly the same on day 2 as they did on day 1. Chronic fatigue patients were impaired in the red on day 1 and baseline. You can separate them. Their performance is not as good. But look at the performance on day 2. It drops markedly. It drops, in fact, to that disabled zone. So this is a very, very interesting, cheap, and useful test that we're using a lot now to demonstrate the post-exertional malaise and to be able to quantitate it. Sometimes it's difficult for patients to do treadmills 2 days in a row, particularly since the second one may put them to bed for a week or 2. But it demonstrates our point very well. So obviously multi-systems are involved in ME and CFS. It's so many that I think it's daunting for people to try to understand. We know that the brain dysfunctions, there's altered perceptions, there's neurocognitive changes, there's mood changes, there's sleep disturbances, and these are probably mediated by the cytokines, I believe. I don't think it's a structural brain injury. There are risk factors, infections, genetic makeup, gene environment, the HPA axis. We've talked a bunch about that. It's been proven that you have orthostatic intolerance. Your blood pressure goes down when you stand up instead of goes up. Your heart rate goes up inappropriately. But exactly what's causing that remains to be determined. It's one of the reasons that this disease has been so difficult to study, because it involves so many different symptoms and systems. And oftentimes a specialist, for example, a neurologist, will just look at the CNS and say, well, the MRIs are okay, or you're moving all your limbs okay, and not realize all the other systems that are involved. An endocrinologist will know the HPA axis and will not even consider the immune derangement that's associated or the functional abnormalities that are associated. What are the possible causes of CFS? Well, infectious agents have been implicated, immunological abnormalities, the HPA axis, neurally-mediated hypotension, even nutritional deficiencies. In the US now, there's a lot of fatigue clinics that allege to cure you with a variety of lotions and potions, as I call them, that all you need to do is go to the clinic and take what they recommend and you'll be cured because you had some nutritional deficiency. There's an Agent X theory, and Agent X says that you were affected by something that then caused immune suppression, that then caused overactivation of your immune system, producing symptoms, and it's a cycle that stays persistent even if Agent X is now no longer present. And I think that's the leading theory amongst the people who are researching this disease, at least in the United States. You can explain this more fully by the action of cytokines. The macrophages suppress NK cell function. They have abnormalities of T and B cell dysregulation. So this particular Agent X model would explain a lot of the immune problems we see in the disease. There's a channelopathy theory. This is a European theory, and this says that the cell membrane is affected with low body potassium, with low blood volume, with hypotension, with bronchial reactivity, with increase in prostaglandins, with low magnesium. These are indeed measurable defects, but they're probably secondary. They're probably not the cause. If you did away with the cause, all of these mechanisms would probably disappear. We do use the channelopathy theory for therapy, however. There's some patients who benefit a great deal from saline infusions, just getting up their blood volume. Their dizziness goes away, their weakness goes away. There's nitrous oxide theories. This is a very nebulous area of medicine. It's probably true. The nitrous oxide story is very obscure. It's very interesting, but it's very hard to measure. Nitrous oxide is around for only a few nanoseconds. So to measure it intercellularly is nearly impossible. We just don't have the tools. So it's very theoretical now. But there's a lot of clinics and things that are using glutathione, etc., to treat the supposed abnormality of the mitochondria. A proposed model that most people accept for purposes of discussion. There's a number of studies that show you have a genetic predisposition, but not much. It's a very small genetic predisposition to develop this disease. Environmental factors clearly play a role, such as stress, chemical exposure leading to immune dysregulation, which then sets you up for an infection, whether it's bacterial, viral, fungal, parasitic. You get a breakdown of the immune system and an overregulation, and that results in these symptoms of chemical sensitivities, chronic fatigue syndrome, and multiple allergies that I'm certain all of you patients feel. Past research has looked largely for a single agent. We spent many, many years looking at one cause of chronic fatigue. We thought we could just find the virus that caused it, voila, we'll be home free. And the background on that is that infectious agents indeed trigger and perpetuate CFS. Most everybody in the United States, 70% of the people, claim that their illness began with an acute infection. So it was logical to look there. Pathogens have many things in common. They're difficult to exclude. They're difficult to include, particularly the herpes viruses. And the herpes viruses have been associated with chronic fatigue syndrome for years and years and years, and are particularly interesting to me because they have the ability to last in your system forever. They impair the immune system. They reactivate with stress. They cause fatigue. They cause swollen lymph nodes, and they cause lymphoma. So they're excellent candidates as far as I'm concerned. Other associated infectious agents, parvo B19, Jonathan Kerr in London thinks that people who have been exposed to parvo B19 develop chronic fatigue-like illness. Enteroviruses are back on the scene. These were initially alleged to be involved by Dr. Gow, etc. in Scotland. We now know, if there's work from Dr. Chia in Los Angeles, that the enteroviruses seem to be very active in the guts of patients with chronic fatigue syndrome. The rickettsias are known to cause chronic fatigue in Australia. So maybe it depends on where you live, what agent caused your disease. And mycoplasma have always been implicated. The mycoplasma story is interested. It may be a comorbid relationship with mycoplasma. You might have known that there's theories that mycoplasma play a role in the Gulf War syndrome. Interestingly, patients with Gulf War syndrome and mycoplasma infections do have an abnormal RNA cell. Something really interesting that just came out in the US literature is that a subset of children with autism have impairment of their antiviral pathway. So it may be that these are common immune mechanisms that we see across groups. I'm particularly interested in the patients that have predominant central nervous system symptoms, because I think most people are disabled actually not by the fatigue, but their inability to think properly and to process properly. So I take particular attention to the patients that have headaches, neurological impairments such as word finding, short-term memory problem, paresthesias, autonomic dysfunction. And in this group of patients, almost all of them have abnormal MRI scans with increase in T2-weighted images in the high white matter tract, very similar to multiple sclerosis lesions. Now, I know these particular imaging techniques are rarely used in Ireland and the UK, so I dare to say probably none of you have had MRI scans. But I'd also say that if you had, I'll bet you most of them would be abnormal. Secondly, brain SPECT scans, which detect perfusion. It's not a structural scan, it's a functional scan. And we find areas of hypoperfusion, underperfusion, whole areas of your brain not getting a blood supply. That implies brain injury of one sort or another. These are characteristic findings. Almost every patient has an abnormal SPECT scan. The importance to that is there are things you can do to increase regional blood flow. It's particularly useful in relieving the headaches and improving your cognitive function. I went a step further and I said, well, maybe I could find something about the spinal fluid that told me about what's going on. So I did a series of lumbar punctures on 150 patients. And indeed, the patients had elevated opening pressures. They had increased total protein, especially myelin basic protein. And for those of you who are unfamiliar, that means inflammation. And lymphocytosis. So in fact, it does appear that you have an encephalitis, just as the term myalgic encephalitis implied. And when I looked at this, I wanted to differentiate it from multiple sclerosis because it sounds similar. And none of the patients had oligoclonal banding, which is the hallmark of multiple sclerosis. So it clearly isn't multiple sclerosis. And then I compared the patients whose spinal fluid was positive for HHV6, the herpes virus, against those who were negative. And I found dramatic differences in the group of patients who had this infection with HHV6 variant A in their spinal fluid. And when we looked at these, out of the 150 spinal fluids we did, 29 or 20% were positive for viruses. And the viruses we found were all herpes viruses. One patient with EBV, one with CMV, 27 with HHV6, all were variant A. The interesting thing about finding these is that it's treatable. There are antivirals for that group of people who have encephalitis. And the most successful has been Vistide. There's also poly-I, poly-C12U, or Ampogen, and herpes virus transfer factors available. So I only make this point to say that this dismal thing about there's nothing you can do about your cognitive dysfunction, et cetera, if you're in this subset of patients who have an abnormal MRI scan, abnormal SPECT scan, and have a virus in your brain, there's everything that you can do. Of 8 people to date that I've treated with this, 5 have returned to work full time. Current research. I promised to talk and titillate you a bit about what's going on now. And the first is gene profiling expression. This is very exciting. It's happening in every disease known to man because it's easy to do, it's fairly cheap. We've looked at DNA profiling, and there's not a whole lot of difference between chronic fatigue patients and normals. We've looked at SNPs, and SNPs are single nucleotide deficits. We're looking for one gene defect that may predict who you are, like Huntington's or sickle cell anemia, and those studies are ongoing, but it doesn't appear to be that you'll have one single gene defect. So then we looked at messenger RNA, what's actually happening in the cells at the time, and there we find very interesting profiles. And I'll show you a little bit about it. Both Jonathan Kerr in London and the CDC have published that they can differentiate you from the rest of the world based on your gene profiling. And to summarize it, in the gene profiling, it looks like you're aging more quickly, the apoptotic genes are turned on, and your mitochondria are turned off, and your many aspects of your endocrine metabolism are down-regulated. So it would fit pretty well the symptoms that you have. We're doing that longitudinally now over time to see if it holds up in more points in time than one. I have an interest in this group of patients that's developed a T-cell receptor gamma rearrangement, and the reason for that is that I have 19 patients who have developed lymphoma. And in fact, if you have a disease that's going to end up in lymphoma, I want to know about it early so that I can institute aggressive therapy. It's a very unique defect, and we're studying it with the National Cancer Institute to see if that data particularly holds up. There's a group of people who have chromosomally integrated HHV6. That means that particular virus has inculcated itself into their genetic code. and they have HHV6 in every cell in their body. We assay it through their hair, and they can pass it along, in fact, to their children. And then we're using cytokine and proteomic profiles with antibody arrays. These are really exciting. They're easily done. They're relatively cheap, and they give us your whole cytokine profile. It gives us 25 profiles in just seconds. And we can follow you over time as we develop therapeutic strategies. So the hypothesis that we've been working on is that co-infection of viruses and HHV6 can trigger chronic fatigue syndrome with a dysregulated immune response, and that this may lead to the T-cell dysregulation that eventually develops into lymphoma. And that's the basis of our research grants with the NCI. Here's some work from the CDC showing that they can differentiate by genetic profiling you from everybody else and you from your neighbor. They have subsets. And for example, people who have been exposed to organophosphates, and that's a cause of their chronic fatigue, look totally differently than the patients who had an enterovirus infection. Here's some of Jonathan's work that on the left-hand side is the controls, on the right-hand side are the chronic fatigue patients. And he's looking at a gene that controls Epstein-Barr virus replication here. And you can strongly, I mean, without being a scientist, you can see there's a difference between the chronic fatigue patients and the normal controls. The CDC published similar genetic data, and they looked at non-fatigue patients versus ISF, which are kind of people in between who don't quite meet their criteria but have some symptoms, versus the CFS patients. So even on genetic screening, they can differentiate chronic fatigue patients from normals. The problem with this kind of testing is it doesn't really tell you what's going on. It simply tells you match a profile that we identify as chronic fatigue syndrome. Well, we finally have started to look at virus microarrays, and this is really kind of exciting stuff. Because what we did is we got a grant together for a viral chip that looks for all 4,000 known human viruses. And we said, okay, if there's a virus involved, let's start looking. And interestingly, what we found is, and we haven't finished looking at this data, but chronic fatigue patients are crawling with viruses. I never expected it. Some patients have 50 or 60 viruses active on the day that we test their blood, versus the controls that may have one or two, may have influenza or adeno or something like that. So the problem is actually much, much bigger than I originally anticipated. We did this study together with Jonathan, and interestingly, across the studies, there's 9 viruses that all the patients have in common, whether they came from UK or came from the US. So we're obviously looking very hard at those 9 viruses. Patterns of virus expression can definitely differentiate chronic fatigue patients from controls. It's going to be easier and easier and easier to do this. It basically takes a drop of blood and we get back results on 4,000 viruses. So look for that to be coming and published in the near future. We also looked to see if we could find virus in the patients that develop cancer, because a lot of lymphomas are related to viruses. So we're studying my 19 people who have developed lymphoma. Dr. Knox is looking at cell membrane STAT1 proteins. This is a very functional, this is looking at why the immune system isn't working and what you might do to fix that. And I make a plug for our repository for worldwide research. A couple of years ago, we had a generous donor who set up a repository so that people from around the world who want to do research in the area of chronic fatigue can access blood specimens, spinal fluid specimens, tissue specimens from one source. And through this generosity, we were able to set up the tissue repository. And we get requests from around the world from people who either want to donate blood, spinal fluid, or body parts to this repository for future. And we've figured out the logistics to make this happen now. So I say spread the word if you have researchers in Ireland that want to access that repository, or people who want to donate to it. We accept both. But it's a brilliant way of looking for gene expression profiling, virus expression profiling, epigenetic profiling, which is environmental stuff, other people who were exposed to toxins. I didn't take the time to show this, but on Jonathan's array, he's found people who were exposed to organophosphates in their work. And that's very interesting. And inflammatory mediator expression, these are the cytokines, the exciting research because there's a lot of cytokine blockers. So there's a reason to look at cytokines because if you have a markedly elevated interferon, for example, it might be useful symptomatically to block that. And the last thing I wanted to talk about is how the world is changing with respect to medical research. And we're moving into the age of informatics. And most of you are probably not totally familiar with informatics, but informatics is an entirely different way of looking at and delivering healthcare. And it's driven by a more cost-effective model. And what it says is that using informatics, forgetting about people's symptoms and things like that, we can look at host response signatures, we can look at surveillance studies, we can do clinical trials, and we can upscale this to a cost-effective strategy. Very similar to, many of you know how DNA is used to catch criminals now. As the data bank of people gets bigger and bigger and bigger, it's easier to catch the bad guys because the reference is far greater. It's the same in disease. The reference files now for DNA and RNA are huge. The databases are huge. So if you find something, it's very easy to reference it against normals and to share research. It's called informatics. And what informatics uses the concept of conversion, and it says we take your genetic profile, which people can buy now. We take databases from around the world to compare. We take biotechnology, things like the microchip that I just described to you. We then apply clinical medicine, and we come out with an individualized diagnostic and therapy. Now, a lot of physicians don't like this because they think it's taking away the art of medicine. But the art of medicine didn't work very well, so that's why everything's moving in this direction. And I'll just show you a little schematic here so you all understand what this actually means. Now, in the past, when you had some symptom, you got a test. And then you had more tests. And then something was diagnosed. And then something was done, and maybe you recovered, maybe you didn't. Maybe you continued having symptoms. And I suggest to you that all in this room, that's been your course through chronic fatigue, and the circle just keeps going and going. It's an old paradigm. We all used it. It doesn't work. So here, offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm going to order a bunch of tests. So an improved paradigm that is starting to come about in the United States is one that says we can short-circuit this if we use informatics and genomics. And we can say, you're predisposed to develop something. I will do the 4,000 virus screen first. I will then find out about your symptoms. I will then update your genomic profile and give you a specific therapy that leads to recovery. So theoretically, it's a much, much more efficient model. It'll be more cost effective. It will feel more mechanical to you, but it will yield a better outcome and be hopefully cheaper. So we don't have to face this. I'm stumped. We'll wait for the autopsy. So in summary, we believe that there's a unique host response expression that can be used to define any disease. And it doesn't matter if you have 4 of 8 symptoms or 10 of 8 symptoms or 12 of 8 symptoms, you'll be defined on your genetic gene expression profile. And this signature can be susceptible of disease and predictive of disease. And that there are unique expression signatures that also indicate what therapies to use, which will allow me to choose my therapy much, much better. And so when we compare clinical medicine as practiced today with genomics, you'll find that we redefine disease from a molecular basis rather than from a group of symptoms. We then build a nosology based on your gene expression. We build your profile that's only you, and we say this is what's wrong with you based on what your gene profile looks like today. And we can utilize that in a predictive fashion when we go against databases. And we say people with your profile respond to this drug or respond to this therapy versus don't. And when we apply that to chronic fatigue, we find that a subset of patients with CFS have symptoms from ongoing viral replication from immune dysregulation. We're already using this model. We can identify that group of people and we can treat them with antivirals. And theoretically, this should apply to all the other patients with other causes. So given a nonspecific clinical disease, we can now direct disease definition, screening, and treatment. We don't have to use these cumbersome definitions that everybody argues about that have crossovers with depression and anxiety and panic disorder and bad mother syndrome and everything else. And thus at least view it as a treatable disease with a unique host expression signature that results in specific therapy and recovery. And that's our goal now in 2008 in CFS. Thank you all.